Establishing and supporting breastfeeding. This is a second-year breastfeeding session. The aims of this session are to review available current statistics and review the evidence base on the benefits of breastfeeding, to evaluate the impact of social and cultural attitudes towards breastfeeding, to apply the physiology of lactation to the practice of breastfeeding, and to evaluate the promotion of breastfeeding and midwives' practice and the effect of breastfeeding policy. As you can see from the statistics, initial breastfeeding rates are increasing, as are the breastfeeding continuation rates. However, the breastfeeding rates at 6 weeks and 6 months remain quite low. Statistics in Leicester, Leicestershire and Rutland, these are similar overall initiation rates with corresponding lower breastfeeding rates on transfer home. Women from disadvantaged areas and groups see even lower intention rates and lower rates of breastfeeding on transfer home. And these reasons reflect the national picture. Eight out of 10 women who experienced problems received help and advice, but those who had not received help were more likely to stop breastfeeding within 2 weeks. And introducing formula feeds increases the chances of complications, such as blocked ducts and a reduced milk supply. So how do women feel about breastfeeding? Breastfeeding is thought to be synonymous with being a good mother, and unsuccessful breastfeeding can make a woman feel poor as a mother. Positive attitudes such as seeing other women breastfeeding all are positive determinants of feeding intention. Often, breastfeeding goes against normative practices within cultural and social groups. We are very much still a bottle feeding culture within the UK, but not within all social groups. Breastfeeding is seen as part of the mothering role with the aim of achieving a happy, healthy baby. Perhaps have a look at that article from Marshall in 2011 to look at these ideas in more detail. Studies stress the importance of support, peer support, family support and midwifery support, and there have been significant difficulties reported when returning to work. Reasons cited for stopping breastfeeding before 6 weeks include such things as lactation and nutrition concerns, such as insufficient milk, pain on feeding, the baby rejected the breast, illness in the mother or the baby, returning to work, and other, but obviously recognising that mothers may cite more than one reason. Compared to locally, Austin and Patterson in 2010 undertook a study of women and breastfeeding locally, and they also identified lack of help and support, problems such as sore nipples, competing demands between work and family and caring for others, and worry about partners as all reasons why women may stop breastfeeding. There are many types of breastfeeding. If you look in the literature, they often talk about exclusive breastfeeding, mixed feeding, breastfeeding rather than exclusive breastfeeding are very different categories. And this is important that you understand the categories of breastfeeding, especially when trying to read and understand the research around breastfeeding, such as exclusive breastfeeding is total breastfeeding 24/7. Mixed feeding would be the giving of formula feeds alongside breastfeeding. And we know this, if this happens in the early weeks, it can seriously undermine breastfeeding success as it interferes with the establishment of breastfeeding. The gold standard is breastfeeding should be exclusive up to 6 months of age and then continued up to 2 years and beyond. World Health Organization 2000. But what's the effect of the occasional formula feed? We know that a lot of women will give the occasional formula feed. Once breastfeeding is established, The evidence is less clear, but we know that giving the occasional feed in the early period can influence breastfeeding success while breastfeeding is becoming established. But what's less clear is the addition of an occasional formula feed, which doesn't appear to undermine the protective effects of breastfeeding, especially if it prolongs the time actually spent breastfeeding. Women often want information about breastfeeding, and to enable them to make an informed decision about how to feed their infants, whether to breast or to bottle feed, midwives need to be very clear of the benefits of breastfeeding, or conversely, the consequences of the woman, the child, and to society of not breastfeeding. So you need to be thinking about the advantages of breastfeeding from a mother's perspective, a neonate's perspective, and even from society's perspective. Benefits of breastfeeding from a maternal perspective are varied. There's just a few here on the slide, such as decreased risk of developing breast cancer, ovarian cancer, cervical cancer, osteoporosis, and anemia are all reduced through breastfeeding. There's the contraceptive effects of lactational amenorrhea, which could be a useful addition for the mother's health. It enhances maternal well-being. We've got the increases in oxytocin and the prolactin, which help the woman's emotional well-being. Increases in fat store mobilisation, so fat that she's stored during pregnancy to use for labour and breastfeeding are then mobilised. Improved uterine involution. We know that the oxytocin causes the uterus to contract and involute in the postnatal period, and that helps the woman return to the best physical health. And decreased financial costs. Although bottle feeding is thought to be more costly, there are some hidden costs to breastfeeding, such perhaps changes in employment that some studies may not have taken into account. Again, the benefits of breastfeeding from the neonatal perspective are many, and there's just a few on this slide. But things such as decreased rates of obesity in childhood, less gastrointestinal disease, less respiratory disease, less otitis media, less speech delay, especially in boys, less atopic disease, less cardiovascular disease in later life, better developmental performance, including such things as increased IQ, which is especially important for the preterm infant, better overall immune response, less risk to the baby associated with the poor preparation of feeds, and the fact that breastfeeding offsets the negative effects of poverty. Benefits of breastfeeding from society, again, are varied. Less healthcare resources needed, or perhaps not less healthcare resources, but perhaps the reallocation of healthcare resources, rather than having the healthcare resources linked to coping with ill health or morbidity. We could actually put those healthcare resources into perhaps more midwives, one-to-one care in labour, so the reallocation of healthcare resources. And we know that the NHS could save around £35 million per year from not having to treat babies with gastroenteritis. Decreased pollution from waste packaging. Even if the waste is recycled, there's still a lot of waste associated with bottle feeding. Less negative effects of dairy herds on the environment. We know that methane is a major contributor to the greenhouse effect. So if we didn't need such huge dairy herds producing the milk that then we modify to give to our babies, then that might reduce the amount of methane seen as a major greenhouse gas. Important effects of increased child spacing, which is important in areas of poverty with lack of contraception, so especially in developing worlds. And the possible decreased social welfare costs, perhaps due to less chronic ill health in later life, less cardiovascular disease, less obesity, which we're seeing in huge amounts in our current society. Decreased trade deficit in formula importing nations, so the money could be spent on other social improvements. So lots of benefits to breastfeeding from society's perspective. There are some women who, for lots of different reasons, you would advise against breastfeeding. So have a sort of a think about which women you would advise shouldn't breastfeed. And are there anything you could consider promoting instead to help a lot of the benefits that breastfeeding might give? Maternal infection, hepatitis B, HIV, especially women who are HIV positive, breastfeeding may increase the risk of maternal infant transfer. Maternal medication, women who have certain medications for certain conditions, not necessarily would not want to breastfeed or can't breastfeed, but you need to perhaps talk to the pharmacist or talk to the physician, either antenatally or postnatally, to think, are there any other options for treating her condition, which then allows the baby to breastfeed. Maternal treatment, if the woman has, say, developed breast cancer during pregnancy, then she may want to stop breastfeeding or breastfeed for a shorter amount of time so that she can have either surgery or treatment for her condition. And environmental contaminants. There may be certain situations where there may be contaminants in the breast milk that you might need to think cautiously about advising women to breastfeed. However, most women, 97%, are physiologically able to breastfeed. So in consensus, we know that formula feeding is widely available and adopted by parents as a safe alternative. However, the increasing evidence base shows that this is not the case. The benefits of breastfeeding are widely known, but hazards to bottle or formula feeding is less well publicised. Midwives, therefore, have a crucial role in helping women to make informed choices. We need to consider the society's aspects around breastfeeding. So society's attitude towards the breast. Breasts are seen as sexual objects, and the erotic nature of the breast within the media has an influence on seeing breasts as breastfeeding tools. The media influences breastfeeding. There's limited exposure in soaps, for instance. Most of the images are of bottle-fed infants. We see a lot of celebrities now who are breastfeeding, which helps to promote breastfeeding within society. Families' attitudes towards breastfeeding is really, really important. Family support's important, but previous generations have a tendency to bottle feed and see their way as perhaps the best way of feeding a baby. There's limited experience of mothers, aunts, sisters, so less advice and support is available within families. So families themselves need direction and guidance to support the breastfeeding mother. Partner support is really important, crucial for breastfeeding support, as long as it supports obviously what the mother wants, and can support women by performing other childcare tasks, for example. Attitudes of staff, midwifery staff in particular. We all have our own attitudes toward breastfeeding, and this influences the care we can provide, especially depending on how the midwife chose to feed her own children. And if she didn't succeed in her own breastfeeding experience, that may have an influence on how we support breastfeeding mothers. And breastfeeding in public. There's still a bit of a stigma about feeding in public. See the Infant Feeding Survey in 2005, although this is improving. Cultural aspects are really important when we look at breastfeeding support. Culture exerts a major influence on a mother's attitude towards breastfeeding, both the culture of the family and of society. Culture is the values, beliefs, norms and practices of a particular group with specific codes of behaviour through learned and shared thinking. So consider the effect of the dominant culture. This is multicultural Leicester. However, the dominant white view is that breastfeeding is best, but it's still difficult to establish and should be done in private. Consider the effects of ethnocentrism, effects of judging others by one's own belief system. such as a biomedical model that midwives are socialised into, which is basically white and middle class on the whole, and then tensions between the biomedical and social models of care that perhaps someone like Walsh in 2011 discussed. To appreciate cultural differences and treat others with deference to their cultural beliefs, building on their knowledge base. We need to assess cultural practices. It's important to find out about an individual's attitudes and beliefs around breastfeeding and respect the mother's practices. Are they helpful? Are they harmless? Are they harmful? And we need to meet cultural needs. And so you need to perhaps consider what cultural beliefs you've experienced while you've been on your community placements. And also consider the language issues. This limits interaction and information giving, and the use of interpreters over family is preferred. Promoting breastfeeding should start in the antenatal period. We should discuss breastfeeding intention during antenatal care, and perhaps gently challenging attitudes towards breastfeeding. The value of meaningful and antenatal conversations was stressed by UNICEF in 2013 as important during antenatal care. Antenatal education is important for breastfeeding success, although we know only around 1 in 10 women attend, and breastfeeding within antenatal education is limited. But it's really important, especially perhaps for young mothers, to promote breastfeeding to women in the poorer sections of society. As we know, breastfeeding can offset some of the negative aspects of poverty. And antenatal education appears to increase breastfeeding duration, especially if that's done by peer counsellors. We need to provide written information. Pictures are important and provide powerful images, useful for when difficulties arise. And written information across various languages is also important. And perhaps other media, perhaps the DVDs, CDs, internet sources are all important to provide that support. Promoting maternal confidence. Mothers who are most likely to breastfeed are those who are committed to making breastfeeding work, so promoting her belief in herself and her ability to breastfeed is important. And addressing women's prenatal concerns. Women's Recall suggests that healthcare professionals do not always address women's concerns effectively. The initiation of breastfeeding is really important. We know that early initiation of breastfeeding increases breastfeeding success. An effective breastfeed on delivery suite improves a woman's confidence and reduces anxiety by the midwife, also reducing incidences of formula milk feeds and therefore increases overall success and continuation rates. Skin-to-skin contact continued until after the first breastfeed is recommended by UNICEF and Baby Friendly. We know that early contact increases the rates of breastfeeding success, and all healthy term babies should have unrestricted skin-to-skin contact until after the first breastfeed. Breastfeeding can then be initiated once the baby shows signs of readiness. And skin-to-skin also promotes babies to suckle who are reluctant to feed. So continued skin-to-skin contact allows for true baby-led feeding, and rooming in is essential here. Benefits include adaptation to extrauterine existence, higher body temperatures, higher blood glucose levels, less crying, and a reduced risk of PPH. And even when the baby's been born by caesarean section, it should be possible to initiate skin-to-skin within 30 to 40 minutes of birth. The effects of labour care on breastfeeding duration and initiation is important. Use of analgesia such as pethidine, a tied mum and baby, use of an epidural where she's unable to adopt an effective position, an operative birth, and perhaps lack of access to skin also reduce the success of breastfeeding. So the role of the midwife within the first few hours after birth is to provide an unhurried approach, less of a conveyor belt approach to care after birth, giving the mum and baby time to get to know each other, to bond, and ideally to breastfeed while still on delivery suite. So early initiation of breastfeeding soon after birth is important, and we need to be able to teach mums to look for feeding cues. So it's baby-led feeding, especially at night. We know that prolactin levels are higher at night, especially in the first few weeks. So it's really important, if at all possible, the mum will feed at night. Correct positioning attachment will prevent, if not all, breastfeeding problems. So breastfeeding problems are not necessarily a rite of passage that the mother has to go through to successfully breastfeed. It's correct positioning attachment to prevent those complications occurring in the first place. Avoidance of bottles and teats. Don't use dummies. Use a cup or spoon to give express breast milk or artificial milk if that's necessary. And then breastfeeding exclusively for up to 6 months of age and continued up to 2 years and beyond. Promoting breastfeeding in the postnatal period needs to consider the role of the postnatal visit and the role of the midwife within that postnatal visit, giving time to support breastfeeding within a community-based setting. Selective visiting, which was an important initiative brought in the 1990s, this must be woman-centred rather than service-driven to meet individual needs. We need to consider the role of specialist midwives. Individualised support is important to certain groups, perhaps teenagers, so the role of specialist midwives is important here. Continuous skin-to-skin helps reluctant feeders, helps bonding, helps breastfeeding in general. And making sure that mothers got access to support. Midwifery care is available 24/7, however we may not be visiting every day and we're not visiting all the time. So they need to have telephone contacts to gain support, whether it's from peer supporters, whether it's from helplines, or whether it's from midwifery support. Recognising postnatal depression. We know there's increased rates of breastfeeding success if postnatal depression symptoms are recognised and managed. And maternal stress reduces the rate of breastfeeding success. We need to recognise domestic abuse. Abused women are overrepresented amongst mothers who choose not to breastfeed or who cease early, and these need to be identified, supported and referred. And returning to work. Low-income women often have problems combining work and breastfeeding, so it's important that we help women return to work and breastfeed for as long as they wish to. Reality versus idealism. Hodinot et al. In 2011 looked at this concept. And confidence and reassurance are really important, as much, if not more, as teaching the correct technique. So that emotional support that we give to women and their families is really, really important, especially where they've perhaps not got the peer and the family experience around breastfeeding. So we need to be looking at a family-centred approach, family-centred parenting models, so recognising family well-being and the competing priorities on time. Women and family-centred help and support is really important, support that focuses on individual circumstances, and stressing that breastfeeding should continue for as long as you want to, rather than the exclusive for 6 months. So we're valuing, as UNICEF suggests recently, valuing any breastfeeding and for as long as the woman wants to. Recognising good attachment, I think it's quite important that we just spend a couple of minutes looking at what is good attachment. So there's 4 key signs which can be observed to indicate a good attachment to the breast, such as more of the areola seen above the baby's mouth than below, that the baby's mouth is wide open, that the baby's lower lip is curled outwards, and the baby's chin touches the breast. But there are other signs, so you need to be really clear at what those other signs are that indicate good attachment. And I would suggest looking at the UNICEF Baby Friendly Initiative website. There's a really good video clip in there that goes through attachment and positioning. So you really need to have a look at that if you get the time. We talked a bit about support, well, a lot about support for breastfeeding mothers as being crucial. But what other support is available for breastfeeding mothers? Obviously, we've got midwives, healthcare assistants, health visitors, GPs. But there's also voluntary agencies and groups such as La Leche League that will give advice and support. Internet sources are commonplace out there on the web. There's websites providing stories, personal experience, and while they may not be peer reviewed, they are really important sources of support for breastfeeding women. Written information, magazines, parenting magazines are all out there. We give out at the local trust written information, and especially in picture form for women and their families. Friends, family, again, crucial supporters of the breastfeeding woman. And then there's peer supporters. A lot of groups, a lot of areas in Leicester, for instance, have peer support groups within the child health centres, such as bosom buddies, that are women who have had recent experience of breastfeeding, have been educated around breastfeeding to be able to provide that support. So they are really, really crucial for the local community to continue with breastfeeding. So see what's on in your community area when you're next out on placement. So in conclusion, breastfeeding has major benefits for the mother, the neonate and society. And it's really important that you understand what those are so that you can give that information to women in a non-judgmental and sort of discursive discussion. However, you need to make sure you've got that information because women need that to make informed choices. Values, attitudes and culture all play significant roles in breastfeeding uptake and success. So you need to be aware of the values, attitudes of yourself, as well as the values, attitudes of the society and the cultures that you come across within your practice. But the role of the midwife is crucial to breastfeeding success. We're pivotal in improving breastfeeding uptake and initiation and continuation, and that support is a crucial part of the postnatal care that we provide within the community.